Hello, I'm Jenna Sarvadio. I am an associate professor in the Division of Endocrinology, and I'll be giving you guys a short presentation on menopause and POI. Okay, so the overview of this talk is to discuss the landmark trial, the Women's Health Initiative, to when to consider hormone therapy, and then a few slides on premature ovarian insufficiency. So the Women's Health Initiative was a long-term NIH study focused on strategies for disease prevention. So that's key. So they were looking at disease prevention in postmenopausal women. They primarily looked at heart disease. So their primary question was, does hormone therapy prevent cardiovascular disease? And they also looked at outcomes on breast and colorectal cancer and osteoporotic fractures. This study launched in 1993 and it enrolled 808 women. So a huge study. The women were aged 50 to 79 years old, and they were placed into one or more randomized clinical trials. So there are several trials that make up this Women's Health Initiative. And they tested the health effects of hormone therapy, dietary modification, and or calcium and vitamin D supplementation. And I'm really just going to be focusing on the hormone therapy part. At the end of the initial study period, which was in 2005, there was also an extension study, and then that spanned 2005 to 2010, and then another extension from 2010 to 2020. And they continued to follow up all of these women who consented. All right, so these are some of the outcomes of the Women's Health Initiative. So in the hormone therapy group, they looked at women with a uterus and they gave them estrogen and a progestin. Specifically, they gave conjugated equine estrogen and medroxyprogesterone acetate 2.5 milligrams a day. They also looked at women that did not have a uterus, so they were able to give them estrogen alone, so estrogen, which will designate ET, and then those women got the conjugated equine estrogen, same dose. And then the women in the Women's Health Initiative were an average age of 63 years old and about 13 years from menopause. So if we look at the table, I have a column that has the relative risk and then also a column with the absolute risk. And personally for me, I feel like I grasp the outcomes better of studies when they talk about things in absolute risk ways, but the relative risk is super common. You're gonna see it and hear about it and stuff, so I think it's still important to take notice of. Okay, so for the events that were captured for the coronary heart disease, they found in the women that got estrogen and progestin, there were 7 more cases per 10,000 women. In the with the event of stroke, there were 8 more cases per 10,000 women for the women that got estrogen and progestin. For the venous thromboembolism, there were 18 more cases per 10,000 women. And then for breast cancer, there were 8 more cases. And this arm of the study, the estrogen progestin group, was actually stopped early because of the breast cancer. For the estrogen alone, in terms of absolute risk, there were actually 5 less cases of coronary heart disease per 10,000 women. For stroke, there were 12 more cases. For venous thromboembolism, there were 7 more cases. And I think my video is blocking this, but I'm pretty sure for breast cancer, there were 7 less cases of breast cancer in the estrogen therapy alone arm. And then this arm of the study was actually stopped early because of the stroke and the venous thromboembolism risk. Okay, so this slide I'll guide you through, and it's from a paper in JAMA in 2007, and they broke up the findings of the Women's Health Initiative into age groups of women, so 50 to 59, 60 to 69, 70 to 79, and looked at outcomes. So we're really just going to focus on the conjugated equine estrogen in the middle column, and then the estrogen and progestin group on the right side. And so again, you can see for the coronary heart disease, especially in women that were 50 to 59, there looks like there's a lower risk of heart disease in that group of women that got estrogen alone. And it actually looks like as the women age, so 70 to 79, there is more of a risk. So then if we look at the combined group, the estrogen and the progestin, maybe a little bit more risk in the women that are 50 to 59, but definitely less so than the women that are 70 to 79. If we look at stroke and bounce back to the estrogen alone arm, it looks like there's less stroke risk in women that are younger, 50 to 59. And then if we look at the combined, the estrogen and the progestin, maybe a little bit more risk in stroke, but younger women, less risk than older women. If we look at total mortality, it looks like in younger women that receive estrogen alone, as well as estrogen plus progestin, there's lower mortality. And so this is going to set the stage for the next slide, or actually there will be two slides away. So another bit of information is there was a Cochrane review, and it was a meta-analysis of coronary heart disease in randomized controlled trials that were done in postmenopausal women. And the meta-analysis found that hormone therapy initiated less than 10 years after the menopause in postmenopausal women reduced heart disease. And here I have relative risk, so that was 0.52. There was, just like I showed you in the previous slide, there was a significant increased risk of venous thromboembolism, and that relative risk is 1.74. And then death, again, so same story, was significantly reduced, and that was a relative risk of 0.7. And don't quote me on this, but a lot of the data may really be from the Women's Health Initiative, so that might be like why we're seeing the same outcomes. But there were smaller studies that were also done in a randomized fashion, just nothing as big as the Women's Health Initiative. Okay, so then this is what I was alluding to. So this is the timing hypothesis. So when they broke up the outcomes into age ranges, the data seem to show that there is reduced, specifically heart disease in women who initiate hormone therapy before the age of 60 or within 10 years of menopause. And there is a concern of increased risk of heart disease in women who initiate hormone therapy more than 10 or 20 years from menopause. So this is the timing hypothesis. Okay, so then the FDA does have approved indications for hormone therapy. And so these are, so first-line therapy is for bothersome vasomotor symptoms in postmenopausal women without contraindication. So vasomotor symptoms. Hormone therapy seems to be most effective for vasomotor symptoms. It is also Hormone therapy is approved for prevention of bone loss and fracture in postmenopausal women at elevated risk of osteoporosis or fractures. And then for hypogonadism, so for people like in our endocrine world that have pan-hypopit, so don't have pituitary function, or they have premature ovarian insufficiency, which again we'll come to this in a little bit, or premature surgical menopause. Hormone therapy is recommended until the average age at menopause, which is about 52 years old. So this is the FDA approved indications again for hormone therapy. And then low dose vaginal estrogen therapy is recommended first line for isolated genitourinary syndrome of menopause. So vulvovaginal atrophy was a former term for this condition, or simply vaginal dryness. Okay, so I just have a couple of slides on like what is estrogen therapy and what is progestin therapy. So we can use the conjugated equine estrogen that they use in the Women's Health Initiative. The doses are on the right-hand side, and I won't go through all of them. We can use synthetic conjugated estrogens. So these are like in birth control pills. So ethinyl estradiol is the big one that's in conjugated or combined oral contraceptives. And then micronized 17 beta estradiol. This is what we would probably consider like the most bioidentical type of estradiol. And this is probably the most common form of estrogen that we'll use when we are giving hormone therapy in menopause. And then also the 17 beta estradiol patch. Okay. And there are like other treatments too, but this just gives you an idea of simply the estrogens. Okay. And then endometrial protection. So when we give estrogen, we have to protect the uterus in women that have one, because we have found historically that women who use unopposed estrogen develop uterine cancer. So you have to give an adequate dose and duration of a progestogen, or there is a product on the market. It is conjugated equine estrogen plus bazodoxifene, which is a SERM, and that pill actually protects the uterus. And there's only one on the market, and it's called Duave. And then when you do give a low dose vaginal estrogen, you don't have to give a progestogen with that because the systemic absorption of the vaginal estrogen is so low. And then appropriate evaluation of the endometrium should be performed if vaginal bleeding occurs. I usually say, for like a rule of thumb, that within the first 6 months of treatment, bleeding can occur while a woman is like getting accustomed to her hormone therapy. But after 6 months, or if there's no bleeding and then bleeding happens, we should employ our gynecology colleagues to help us evaluate the endometrium. All right, so here's a slide on progestogen therapy. So medroxyprogesterone acetate is the progestogen that was used in the Women's Health Initiative. And then there is micronized progesterone, which we actually use most commonly. And that comes in 2 doses, so 100 and 200 milligrams. And there is actually a progesterone vaginal gel that was used in some studies to protect the uterus. So the differences in progestogens. So very simply, breast cancer risk varies significantly according to the type of progestogen, with no risk seen with micronized progesterone. So the study that showed that, I think, is at the bottom there, and that is one of the reasons that we prefer using micronized progesterone over medroxyprogesterone acetate. And then levonorgestrel IUDs, they do not relieve hot flashes, but they do oppose estrogen. So a woman could have an IUD in place, and then you can give her an estradiol pill or a patch to relieve the vasomotor symptoms of menopause. So here are just a few slides on POI. And so the definition of this is the development of primary hypogonadism before the age of 40. So that means that the ovaries stop functioning. And the woman, has oligo, so irregular periods, or amenorrhea, so no periods for at least 4 months. But you need to, this is where you get labs, because PCOS could also kind of present like this. And if FSH is greater than 25, and we usually get an estradiol level as well to compare to the FSH, and sometimes it's undetectable, sometimes it's just less than 50. And if you're unsure, then you should repeat the FSH level in about 4 to 6 weeks. Just to confirm the diagnosis, because POI is actually a very serious diagnosis. It can be totally life altering for a young woman, so you want to be sure that that's what's going on. And it also has health consequences. So there is thought to be a higher risk of death from all-cause mortality and ischemic heart disease. And there have also been studies that have shown a low bone mineral density, or BMD, increasing the likelihood of fractures. So we do believe that women with POI should be treated with hormone therapy, but there's limited data on hormone regimens and route of administration. There is a study which I'm going to show you that the transdermal application improves bone mineral density, and it reduces cardiovascular risk more effectively than combined oral contraceptive pills. So usually in endocrine, we prefer transdermal over birth control pills. And then the slide I have next is actually not on the cardiovascular risk, but on the bone mineral density. So, in this study, it was published well, it's actually getting a bit dated, so 9 years ago. And it actually is a very small study. So I think we need to be careful. So it's like 12 and 9 women in each arm of the study, something like that. And so one arm of the study was given. So the hormone replacement therapy, if I understand correctly, because this was done outside of the US, and they have different preparations, it was a patch, and it was equal to about estradiol 2 milligrams a day. And then they actually used levonorgestrel 75 micrograms for 12 days a month. I have not really learned to use levonorgestrel alone like that. So that's a little bit different than our typical regimens that we have. And then for the combined oral contraceptive pill, they had an ethinyl estradiol, which is typical, and that's 30 micrograms. And then in the pill, they also had the levonorgestrel, and the dose happened to be 150 micrograms. And they took it for 21 days, and then they had a 7-day break. And so I just included one of the graphs from the study. And so the green group is the group that got a transdermal patch, and the red line is the women that got the birth control pill, and the blue line is women that had that declined treatment, so they didn't want anything. And you can see that their lumbar spine bone mineral density went down over time. If you look at the women that got the transdermal hormone therapy, their bone mineral density increased over time. And then the women with the combined oral contraceptive pill was roughly stable. So you could kind of argue, it is lower, of course, than the women that got the patch. And then there are actually other data, and I'd have to read this study like much more closely, but they looked at the hips and stuff, and it almost looks like the women didn't start like at the same place. So, it's hard to say if they're not starting at the same place with their bone mineral density, what the outcomes really mean. But this was more clear. And so the bottom line from this study, and I think a big takeaway from a lot of endocrinologists, is to use transdermal therapy because it improves bone health more than a birth control pill. And I think that there's actually a more recent study from 2025 that looked at oral estradiol and not a birth control pill. And that data might not be, very different in terms of transdermal versus oral estradiol. Okay, so the key messages that I want you to take home from this, like, little tidbits of menopause and POI, is that hormone therapy represents a safe and effective option for the treatments of menopausal symptoms, so vasomotor symptoms, genitourinary syndrome of menopause, and prevention of bone loss in healthy, younger, postmenopausal women, despite concerns about potential adverse cardiovascular disease in older women. Um, and then the risks of hormone therapy in the Women's Health Initiative and other studies differ overall for the estrogen therapy group versus the estrogen progestin therapy group. So just be mindful of that. And instead, some of you that might be somewhat familiar with hormone therapy, there's this mantra that you should use the lowest dose for the shortest duration. But really, I think a lot of us are advocating that we should use the appropriate dose, so the type of estrogen and progestin matters, and the formulation. And we should use the appropriate route, so maybe transdermal versus oral, for the appropriate duration to meet treatment objectives. So everything, should be appropriate. And then we should perform periodic reassessments of the benefits, the risks, and treatment goals over time. So the older your patient gets, she according to the data, is at more risk for some of these outcomes that were looked at, like heart disease. And then regarding POI, so the data regarding hormone therapy in women over age 50 should not be extrapolated to younger postmenopausal women. So we think that, the benefits of hormone therapy, so the benefits to their bone, and I didn't show you data, but there's some, I believe, observational studies to their heart health. The benefits outweigh any risks of hormone therapy. So just like the FDA says, they should be treated until the average age of menopause.